In this position, the hamstring is disabled and can barely generate any force because it's maximally shortened. So when they pull up like that, and we push down against them, oh, and they say that hurts. That's not very much force because it's on the left-hand end of the, sorry, I didn't mean to crash the table around, the end of the force length relationship. So if a person says, if I think they have a hamstring strain and I do a resisted hamstring curl isometrically in a shortened position and it doesn't hurt them, well, then I'm going to roll them over on their back and lengthen their hamstring. I'm going to flex their hip and put them up in a position not fully lengthened, not into a hamstring stretch, but we'll put them into a position we call the tip-up position. So now the hamstring's in about mid-range because it's extended at the hip, flexed at the hip, but flexed at the knee, and then I'll get them to push it down with their foot. I put my shoulder under their heel and get them to lift their butt off the table by activating their hamstring. We call that a kip-up. It's kind of a slang name. But the point that's, again, the principle that we need to understand is that represents a progression of more difficult challenges. When we get them to resist isometric activation, or when we resist isometric activation at progressively longer positions, each one of those tests will stress the muscle in question with more force. And if we can activate it vigorously at a fully lengthened position and they're still not complaining of pain, then they don't have a hamstring strain. But you don't want to do that as the first test because you might finish it off if it's partially strained and you wrestle with them in a high force position. So we use a progression of difficulties in challenging. They'll be tender to poke. And I'm going back to blackboard again here. I need to put this on the slide so I don't have to do this every year. I mean, I'm going to get some MRIs of a hamstring and put them on here to explain the issue because none of the anatomy books do justice to the anatomy of the hamstring, surprisingly. And I didn't even realize this until I'd been practicing medicine for about 15 years because no one told me. I figured it out talking to the radiologist about someone's MRI. When I sent an athlete with a hamstring strain for an MRI, and they talked about how there was blood along the muscle tendon junction, but the person was tender right in the middle of their hamstring. And I'm thinking to myself, well, that's the muscle belly. What are you talking about muscle tendon junction? Because the stupid anatomy books make the hamstring, each hamstring, they make it look like a fusiform muscle, and they show tendon, muscle, tendon, as if it stops there. Huh? That's what the anatomy book looks like. That's what my anatomy book still looks like. Well, that's not how it is. I mean, that's just such a superficial picture. It turns out the proximal, like if this is the ischial tuberosity, and say this is biceps femoris, and this is the head of the fibula here, you have a proximal tendon and a distal tendon. And the proximal tendon goes down the muscle to about there, and the distal tendon goes up the muscle to about there. And if I do cross sections, this is where the MRIs teach us stuff. So we didn't have MRIs when I was a student, but when we started looking at them in the 90s, I'm like, holy shit, okay, that makes sense, all right. Because what we see here in the hamstring is we see a tendon in the middle of the muscle. And all the muscle fibers pennate into it, they come around it radially like that. And it's pennated, and that gives it so many more fibers. Remember about muscle pennation, you get a lot more surface area on the tendon if the fibers are pinnated onto it, as opposed to having a tendon that's like a stump where the fibers just attach to the end of the stump. That's not how it works. Nature doesn't do that. There's no stump of tendon here. The tendon goes halfway down the muscle or more. And this tendon comes halfway up the muscle. And if you do a cross section in the middle of the hamstring, you see two tendons when you look at the MRI, because you're cutting through both of them. And the most common place that the muscle is injured is the fibers in between the two tendons. Pull off the tendons, and the bleeding happens in here. And that's where I learned this when the radiologist was saying, well, it's pulled off the distal tendon at the muscle tendon junction. And I'm like, it's in the middle of the muscle. What are you talking about? And he was kind of like, don't you know your anatomy? Come and look at the picture. It's like, oh, geez, yeah, I actually did well in anatomy, but they didn't teach us that. They didn't give us sort of three-dimensional understanding. That's changed a bit. And I don't know, do you guys get a lot of cross-sectional anatomy when you do anatomy? No? See, it's interesting. Cross-sectional imaging, like CT scans and MRs, that look at slices, give you an interesting perspective that you don't get when you look at anatomical objects from their exterior only. You say, well, there's the muscle, and you see tendon here, and you see tendon here, and you don't realize. Now, when you eat a piece of meat and you cut the meat next time, look at the anatomy. You say, oh yeah, there's tendon inside it. Look at that. Look at all the fibers going in here. I'm not trying to gross you out, but pay attention. Anyway, and then down here, there's one tendon again. Okay? So all of these hamstring injuries, they're not muscle injuries, they're muscle tendon injuries, but they can occur anywhere up and along because the tendon or the tendons run right through the muscle. There's no point in the muscle where you slice it where you're not going to be slicing through a tendon. So again, first response-wise, you want to modify the person's activity. Maybe they need to go on crutches if they're having a hard time walking. I mean, this is non-catastrophic stuff, but you don't want to let them get worse, so they have to stop running around. And if they're limping is always the thing that tells you somebody needs crutches. And again, ice is useless, and you want to wrap them up. So you want to get a nice circumferential wrap and stop the hamstring from swelling up. How do you prevent this? Strengthening. Now this is one where, and I've kind of covered this off a little bit already, so I'll go quickly here, but on this one we actually have good evidence. So people have looked at different programs of hamstring rehabilitation and hamstring hygiene, if I can call it that, different combinations with different emphases on stretching, isometric strengthening, concentric strengthening, eccentric strengthening, and they've compared different programs. And every experiment that has done this comes to the same conclusion, that eccentric strengthening is the cornerstone of preventing hamstring strains. That your muscle needs to be strong while it is lengthening. Because that's when it's going to get injured. That's the vulnerable context. That's the situation in which you're not going to strain your hamstring when it's short and concentrically active. So going to a weight room and doing hamstring curls in that position, it's like, yeah, whatever. It hasn't been shown to prevent hamstring injury. You want to strengthen your hamstrings in a lengthened position, getting longer. You want to use them as brakes to stop your hip from flexing and your knee from extending. And that's a kip-up. So you're doing an eccentric kip-up. So if you put your foot up on I could really hurt myself if I do this on a table, so I'm going to do it on the floor. This kip-up I'm talking about will be where you use your hamstring to raise and lower yourself. And during the raising, as I'm pushing myself up, my hamstring is concentrically active. As I lower myself down, it's eccentrically active. So what I want to be able to do is catch myself. I want to be able to get up to a maximum height, let my body fall, and catch myself. So a rapid eccentric activation when the muscle is relatively long. Or I could hang over the edge of a table, attach a 20-pound weight to my foot, let it fall, but catch it before it hits the ground. I want to stop it. I want to use my hamstring as a brake when it is in a lengthened position. And exercises like that have been shown scientifically to work. You need to be able to have, there's two reasons to stretch your hamstring, or 3, 4, whatever, but the most important ones in this context are performance related, not injury prevention. They're performance related. If you want to be a runner, you need a long stride length. If you want a long stride length, you need long hamstrings. You need to be able to get your leg out in front of you to run quickly. You need to be able to achieve the target range of motion. And, as I mentioned rapidly in passing, longer muscles generate more force because they contract more rapidly. 6 resting lengths per second of a long muscle is faster than 6 resting lengths per second of a short muscle. So you will be able to move your body faster, generate more power, and have longer stride lengths. For all those reasons, it will make you a faster runner. So in the example of running, yes, you need to stretch your hamstring, but not because it prevents injury. It's been shown that it doesn't really contribute much. They say it contributes 15% of the variance in injury, the length of the hamstring, whereas the eccentric strength of the hamstring is 85% of the problem. Okay, so strength before length from an injury perspective, from a performance perspective, you need both. The major myositis ossificans is not as common in the hamstring as it is in the quadriceps and the adductor compartments of the thigh, for whatever reasons. I guess they don't fill up with blood as much, although they do fill up with blood a little bit as per the diagram, so you can get it. But that's not as big a deal as scarring to the sciatic nerve. I didn't draw it on the diagram, but I showed you the anatomy slides the other day. The sciatic nerve runs right under the hamstrings down the back of the leg. And if you leak some blood from the hamstring muscle and you get some inflammation and scar tissue forming around the hematoma, you can get adhesion of the sciatic nerve to the hamstring. That's going to create discomfort when you run, because when you go into that lengthened position now, you're pulling on your sciatic nerve and it needs to be able to move relative to the muscle. And if it can't because it's stuck to the muscle, you'll get like a sciatic nerve stretch every time you take a stride. And people think their hamstring isn't healed, but it's not the hamstring, the muscle's fine. What's giving them chronic pain after their hamstring injury is the adhesion of the nerve to the muscle. So we pay attention when rehabilitating hamstring strains to make sure that we mobilize the nerve relative to the muscle by doing ankle dorsiflexion, say in a lengthened position, which pulls on the nerve, or doing spinal flexion, which pulls the nerve up, so that we're moving the nerve relative to the muscle and keeping it mobile. All right, any questions about thighs and thigh muscles? We've been on them for a little bit, last class and this one. I'm going to move on to the hip joint after questions.
So you mentioned stretching the sciatic nerve. In fundamentals of human movement, you said that doing a hamstring stretch where you reach that is not effective.
For the hamstring. Because what's going to constrain the movement is the nerve, right. Now, the goal here is not to move the nerve, it's to floss the nerve. So what we call nerve flossing in clinical medicine is when you alternately pull a nerve in opposite directions. If you pull the nerve both ways, the nerve isn't going to move, it's just going to stretch and hurt. So if this is stretching my sciatic nerve because I'm pulling it from above by bending forward, because when I bend forward, I lift my entire spinal cord up and pull all the nerves in my leg. That's a proximal tension on the nervous system. I could be sitting here, I don't have to stretch it from below. Just slumping and looking down pulls my nerves up, okay? Whereas when I'm sitting up straight, I'm not pulling my nerves from above. You pull the nerves from above by slouching and looking down. If I sit up straight, but then straighten my leg and dorsiflex my ankle, now I'm pulling the nerve down. What we want to do to keep a nerve mobile against its surroundings is flossing, alternately pulling it up and down. So we'll get the person to pull the nerve from below, then pull the nerve from above, then pull the nerve from below, then pull the nerve from above, and not pull it in both directions at once, which doesn't move it, it just pulls it. Now, just stretching the sciatic nerve will, if you do it enough, encourage the nerve to grow longer. So if you need to lengthen your sciatic nerve, then you need to pull it from both directions and do it chronically for a long time, every day for years, or months anyway. And the nerve will grow longer. The goal here isn't to get the nerve to grow longer, it's to keep it moving relative to the hamstring, so we floss it. We do what's called nerve flossing. Okay? Other questions? All right, so we want to cover off some hip joint disorders. We're now talking about the femorooccipital or coxofemoral joint, whatever you want to call it. Hip is fine. The hip can be considered a region of the body, but we can also correctly use that word just to refer to the coxofemoral articulation. Hip joint disorders, there are all kinds of problems. The things I want you to understand are these four. And I'm going to talk a little bit about some other stuff, but not really, okay? So, KP 363, we're going to talk about 4 different hip problems. Joint surface degeneration, labral tears, femoroacetabular impingement, and scuffies. That's the nickname for that, scuffy. Okay? Call them scuffies, FAI, labral tears, and this would be called osteoarthritis or osteoarthritis, OA. They are all 4 different phases of the same problem in most cases. Okay? These 4 things are related to each other. And what I'd really like you to understand is the biomechanics of the coxofemoral articulation and how and why these 4 problems are related to each other. That's what I will be asking you on the exam. To explain the sequence of pathology how as a young